guys know that. So, it is not 10 minutes until 8. It's probably like a couple of minutes after 8. So let's go ahead and get started. Dr. Roman is not in town today, so I will be presiding over the grand rounds for this morning. I like history, I like art, and I like music. So for today, what happened today in history, probably the most exciting thing in our history is that this marks the end of the American Revolution in 1781, the day when Cornwallis exceeded defeat, to the American and French forces. I am very excited about the lecture today. Rheumatologic illnesses are extraordinarily common. We know that very recently a pop star, Selena Gomez, just had a kidney transplant, and the cause of her kidney failure was lupus. There have been many artists in history who've had rheumatologic disorders, Renoir, Dufy, Antoni Gaudi. So again, very common illnesses. And to introduce our speaker for today, I'll ask Neil Roberts to come up to the podium.
So today is a Neudstadt Day. The David H. Neudstadt lecture is an endowed lecture that we've had for, I don't know, a number of years, probably 30, you think? And Dr. Neudstadt, who is a founder of the division and moved to the Ohio Valley with his lovely bride sitting over there, in '54 was really the face of rheumatology for decades, and the founder of the division here, and still it's a protector to some extent. Saw his last patient in this building actually in about 2015, so I'll let you do that subtraction for a minute. It may take a minute. So as he taught me to say, good start to a career. The Neudstadt speaker today is Rick Silver of Chattanooga, late of Charleston, South Carolina, Medical University of South Carolina, where he has been division chief and even interim chief of medicine, and still remains there full time. He's the program director of rheumatology. That's the way I know him the best. He's trained 89 fellows, I saw, in the total time there, about 12 of whom we know at the University of Louisville. So that's a remarkable productivity in terms of number of fellows coming out of there, and also the fact that they're academically active enough that we know who those people are. It shows that he's quite the successful role model or exemplar, as well as being a world-renowned researcher in the area of scleroderma lung disease. The thing that I remember the best, really, is that there are about 2 facts that he discovered or popularized that come up every week, basically, for us. One is that ground glass is very important in prognosis of many lung diseases, but particularly scleroderma. And the other is that cyclophosphamide works, and it was the first paper and the first drug that changed anything in scleroderma. It's probably the most difficult rheumatic disease, and it's still the standard care, although 2 years ago, Dr. Silver published another paper that has to do with mycophenolate equivalents to cyclophosphamide. So it's a long story and a really tough area, and Dr. Silver is going to review clinical aspects of that as well as some of the treatment parts. Rick Silver.
Okay, when the speaker can't get his mic on. There we go. Can you hear me? Okay. Well, thank you for that very kind introduction. I only wish my parents were here. My father would have been very proud, and my mother would have believed every word you said. It's a special honor to give grand rounds for a lectureship named for Dr. Neudstadt, who, in my mind, is the quintessential clinical rheumatologist, and so I'm very pleased and honored to have been invited. And in that spirit, most of what I'll talk about will be clinical aspects of scleroderma, and some of it I hope will be useful for board exams and MOC certification, I hope. These are my disclosures, and these are my learning objectives. First, I want to introduce the new classification criteria for scleroderma. I'll briefly review the three main facets of the pathophysiology of scleroderma. And then finally, I'm going to present the case of a historical figure to illustrate the major clinical aspects of this disease. So let's all sort of get on the same page in terms of nomenclature. So scleroderma or systemic sclerosis, and I'm not going to speak about localized scleroderma or morphia. This will all be about systemic sclerosis. In clinical trials, we use something called the modified Rodnan skin score to assess the extent of skin involvement. And as shown here, the body is divided into 17 different regions, and each region is scored from 0 to 3. 0 meaning normal skin, 3, the skin is severely involved, it's hidebound, you can't even pinch it, and 1 and 2 are mild or moderate degrees of skin involvement. So you can have a skin score ranging from 0 to 51. And patients generally will fall into one of these three general categories based on the extent of skin involvement or the presence or absence of another connective tissue disease. So patients with limited cutaneous scleroderma have involvement of the hands and the distal hands and feet, the distal extremities, and the face, but the trunk is spared and the proximal extremities are spared. And this is what many of you would refer to as the CREST syndrome, limited cutaneous systemic sclerosis. The other group, diffuse cutaneous systemic sclerosis, has involvement in the same areas, the hands, feet, distal extremities, but also the proximal extremities and the trunk. So this is what used to be called PSS, or progressive systemic sclerosis. And then there's a group of patients who may have limited or diffuse skin involvement, but they also have features of dermatomyositis or lupus or Sjogren's syndrome, and that's an overlap connective tissue disease. So going back, the original, and it's ironic, these were called the preliminary criteria for the classification of systemic sclerosis. They were developed in 1980, and basically you had to fulfill the major criterion, proximal skin thickening, or two of the minor criteria, sclerodactyly, digital pitting scars, and bibasilar pulmonary fibrosis. And the problem with these criteria were they're relatively insensitive for mild or early systemic sclerosis. But these were the criteria we had until just a few years ago. And I'll present to you the new criteria in a moment. But the problem was in 1980, we didn't know a whole lot about autoantibodies. This was an evolving field, and we also didn't have as much knowledge about the microvascular aspects of systemic sclerosis. And some of the microvascular features are clinically useful, and they're shown on this slide. So you can examine the microvasculature of the capillaries at the nail fold, here where the skin folds back proximal to the nail bed or the cuticle here. And I've shown you three examples. You sort of have to squint. These are done under low-power microscopy, but this is a normal individual, and there are dozens of small capillary loops that are regular in size and location here. This is what you might see in patients with scleroderma. In the middle, you don't even need a microscope. What you'll see is periungual erythema. And if you examine that with a microscope, you'll see that that erythema is due to these dilated capillary loops. And this is what we often see. This is what Dr. Marie called the slow pattern. It's what we often see in people with the CREST syndrome or the limited form of scleroderma. This is what is known as the fast pattern or the active pattern. And in addition to a few dilated capillary loops and some hemorrhage in the cuticle, you see these areas where the capillaries have been obliterated, drop out. And this is what is seen in people with the diffuse cutaneous form of systemic sclerosis. So this test, which you can do at the bedside really with a, not as well as these pictures show, but with a handheld ophthalmoscope, can be a very useful test, particularly in a subject who has Raynaud's phenomenon, and you're trying to determine if that woman has primary Raynaud's phenomenon or if her Raynaud's phenomenon might be the harbinger of scleroderma or another connective tissue disease. Primary Raynaud's phenomenon would give you this sort of normal pattern. If you have Raynaud's phenomenon in this sort of pattern, that patient will, if she doesn't already fulfill the criteria, will develop systemic sclerosis. So take-home point number one, systemic sclerosis is a vascular disease. The other thing that wasn't as well recognized when the 1980 criteria were developed was the frequency and specificity of autoantibodies in systemic sclerosis patients. So the vast majority, 95 to 97% of scleroderma patients will have a positive ANA. And the lesson I give to the residents who are going to be taking boards and to the fellows, if you have a patient who has hard or tight skin and the ANA is negative, that's a red flag. That patient probably doesn't have scleroderma. That patient probably has one of the scleroderma mimics or pseudoscleroderma. So it could be nephrogenic systemic fibrosis, which we rarely see these days. It could be eosinophilic fasciitis. It could be one of these rare cutaneous diseases, sometimes associated with diabetes or with a paraproteinemia like scleroderma or scleromyxedema or a variety of other rare conditions, because most scleroderma patients are going to have a positive ANA. So take-home point number two, scleroderma is an autoimmune disease. And now we know a great deal more about autoantibodies in scleroderma patients. So this is sort of the classification that I showed you before, limited, diffuse, overlap. When we start to look at the autoantibodies that are seen in patients with scleroderma, they fit fairly well into these various categories. And there are now 9 autoantibodies that have specificity for systemic sclerosis. The 3 major ones are the anti-centromere antibody, topoisomerase antibody, and RNA polymerase 3. And as you can see, most patients who have the anti-centromere antibody have the limited form of scleroderma or CREST syndrome. Most patients with topoisomerase 1 or SCL70 is the other term for that, and most with RNA polymerase 3 have diffuse cutaneous systemic sclerosis. And then these other less prevalent autoantibodies can be seen in limited, diffuse, or overlap conditions. And this is of great interest, not just in terms of pathogenesis, but can be very useful for the clinician and can have some prognostic implications for the patient. So we know that the anti-centromere antibodies seen in patients with limited cutaneous scleroderma, those patients are at high risk for development of pulmonary arterial hypertension. We know also that patients who have the RNA polymerase 3 autoantibody, they tend to have diffuse scleroderma. These are the patients at highest risk for scleroderma renal crisis. And also, in the last few years, it's been shown that these patients may have an underlying malignancy. We're not yet at the point to say that anybody with this autoantibody should be screened the way we screen polymyositis or dermatomyositis for malignancies, but you should have a high index of suspicion in this case. And you can see that the other autoantibodies can be associated with interstitial lung disease and other features of systemic sclerosis. So the autoantibodies can be very useful. Remember, for purposes of the boards, these three, which account for about 60 to 70% of all scleroderma patients. So several years ago, the American College of Rheumatology got together with the European colleagues and developed a new classification criteria. So now to be classified as systemic sclerosis, you have to have 9 points. And you can fulfill that with skin thickening proximal to the metacarpal phalangeal joints, with the caveat that you can't have one of those mimickers or pseudo sclerodermas. But 9 points there will fulfill the criteria. And you can see you can get points for various other features of the disease. And what the new criteria do that the old criteria didn't do is they include features of vascular disease that were not included before, and they include the autoantibodies. So telangiectasia, abnormal nail fold capillaries, that gives you 2 plus 2. Pulmonary arterial hypertension, which wasn't included before, gives you 2. So these are vascular features of the disease. Raynaud's phenomenon, another vascular feature. And then if you have one of these three typical autoantibodies, that can give you 3 points. So you can see that these criteria are much more sensitive, and they approach about 90 to 95% sensitivity and specificity. Now, the term scleroderma comes from the Greek and means hard skin. And my mentor, Dr. Leroy, Carwile Leroy, was really the first person to apply cell culture. At the time, it was a modern technique, cell culture, and he cultured fibroblasts from the dermis of scleroderma patients and compared it to those of normal individuals. And he showed that the scleroderma skin fibroblasts produce excessive amounts of collagen, and later this was shown to include other extracellular matrix proteins as well. So if you look at the skin on a biopsy, the epidermis is basically normal. The dermis is markedly thickened. This is a Masson trichrome stain on the right, where collagen is stained green or greenish blue. And you can see that the excessive amounts of collagen in the dermis. And if you look carefully, if you biopsy early enough, in the deeper part of the dermis, you'll see an inflammatory cell infiltrate, primarily of lymphocytes. So again, emphasizing that this has an autoimmune component, but the take-home point number 3 is that this is a fibrosing disease, and the fibrosis, of course, can affect not only the skin, but virtually any internal organ as well. So this is a paradigm that we use for most of our, the top part could be applied to most of the autoimmune diseases, including rheumatoid arthritis, where you have a genetic susceptibility that's not very well understood, and one or more etiologic or environmental triggers can cause an autoimmune process that involves injury to the endothelium, autoimmunity, and culminates in fibrosis. So let's go to a case. In the spirit of grand rounds, we should present a case. And this is a PK who was born in 1879 and died in 1940. And HIPAA only persists for 50 years, so I feel comfortable in telling you all about PK's illness. I have a disclaimer, and this is PK, Paul Klee. So several disclaimers. I know very little about art. I know a little bit more, but not much more about history. And all of Klee's medical records were lost in an accidental fire. So anything I tell you is based on his letters, his diaries, and those of his wife and his friends. So let me tell you a little bit about the patient. So he was born in 1879 in a small town or village, Munkenbuchsee, outside of Bern in Switzerland. His parents, his mother was Swiss, his father was German. They were both music teachers and musicians. And I'll come back to the fact that his father was German in a few more slides, because that has a lot of relevance to the rest of his history. So his parents really envisioned that Paul would be a musician as well, and he actually was a very good violinist and violist, and played in the Bern Symphony as a teenager. But somewhere along the way, one of his grandmothers gave him some crayons or chalk pencils, and he began to take up drawing. And this is what is believed to be Klee's first of over 9,000 works of art. He drew at age 10. Well, you can imagine a young man growing up in a small provincial little village, wanting to become an artist, and maybe a musician. His town was not big enough for him. So he went to the center of avant-garde art at the time, which was not Paris, but was Munich. And there he met a number of very influential artists, most importantly Kandinsky, who inspired him. And these are some of his early works of art. This is one of my favorites because you can see the very fine details in the lines in this drawing. And these are two men who don't know who is of higher rank. So one is bowing and scraping lower than the other. And it's very, very humorous, as many of his early works of art were. And in 1912, Kandinsky and several other artists invited him to be a member of what was called the Blue Rider Group. And he was really very happy, and things were going very well for him in terms of his art career. And then the First World War broke out, and at first he was spared, but then because his father was German and the Germans used patrilineal descent, he was eventually conscripted into the German army. And fortunately, he was never called up to the front, although two of his dear friends who were members of the Blue Rider group, other artists, were called up to the front and were killed in action in the war. Ironically, Klee's job during most of the time he was in the war was painting camouflage onto German airplanes. But this had a tremendous effect on him, the loss of two of his friends and the death and devastation that he saw during World War I. Then between the wars was probably the happiest time of his life. He married and eventually was invited to be a member of the Bauhaus group, which was a group of artists and architects and designers. And he was very happy. He taught the theory of art and wrote a very famous book at the time, until the National Socialist Party took over in Weimar and ran up the flag, the swastika. And so the Bauhaus moved to another city, but the same thing happened there. And eventually Klee left the Bauhaus, and eventually he and his wife left Germany and went back to Switzerland. So we know that in around 1930 he developed his first symptom of scleroderma. Obviously these are not his hands, but this is a good depiction of Raynaud's phenomenon. So he wrote, "There's nothing more hostile than water turning into ice. Never before had I endured such pain in my fingers during such hot weather." And in retrospect, I believe this was his first symptom, as it often is in scleroderma patients. So patients who have the limited form, what we used to call Crest syndrome, well, will tell you that they had Raynaud's phenomenon for years before anything else happened. I'm on the consult service now, and I saw a patient on Monday who we diagnosed, who's in the hospital because of pulmonary arterial hypertension. And she has limited systemic sclerosis with an anti-centromere antibody. She's about 70 years of age. I asked her, when did you first develop color changes and pain in your fingers? She said, when I was a teenager. So Raynaud's phenomenon can precede the onset of scleroderma by decades. In patients with the diffuse form of the disease, the onset of Raynaud's is very close to within months, or sometimes even comes after the development of skin changes. So really, there are different patterns of disease. But this was probably Klee's first symptom. Again, reinforcing the point that this is a vascular disease. And this slide shows you the two most feared vascular complications of scleroderma. So I mentioned the patient in the hospital that I saw earlier this week. This is scleroderma pulmonary arterial hypertension on your right. On your left is scleroderma renal crisis. And this is the histology. These are different stains, but they from different organs, but they show the same thing. This onion skinning, or profound intimal proliferation with virtual occlusion of the lumen here in the kidney and on your right in the lungs. So these are deadly complications of the disease. Now, it's very interesting if you look back just about 30 or 40 years to see what has happened over this period of time in terms of the causes of death among scleroderma patients. And these data come from the Pittsburgh group, Tom Metzger, Jenny Steen, and others. So here you see that in the 1970s, 40% of scleroderma patients who died as a result of their disease died from scleroderma renal crisis. And then something happened. And what happened was, now it's less than 10%. What happened was the introduction of captopril, the first ACE inhibitor, and the first really effective drug to treat scleroderma renal crisis. And you can see that over the years, this has had a profound effect. And scleroderma patients now are more apt to die from lung disease. About 60% of all scleroderma deaths are related to either idiopathic or interstitial lung disease or pulmonary hypertension. So what do we know about Klee's illness? Well, 5 years after he first wrote about his fingers, he's very sick. He's now in Switzerland. He has bronchitis with heart and lung involvement, and for reasons that are unclear to anybody, he was thought at first to have measles. Perhaps there was an epidemic of measles going around at the time in Bern. It's really not clear. Here he is with his wife and his favorite cat, who is in this one of his paintings. A year later, his wife wrote, because of problems with his skin, so again, now 6 years after the onset of Raynaud's phenomenon, he has some problems with his skin. A number of blood tests are done. The physicians insist now it cannot be measles. What is it then? In any case, it's a miracle that he is alive. So it's now 6 years after his first symptom. He has skin involvement, and the doctors can't figure it out. And this is not unusual, even now. So there can be a very long delay in between the onset of symptoms and the first diagnosis or definitive diagnosis of the disease. Now, around this time, Lily and Paul are back in Switzerland, and the Nazis have taken control. And many of you have seen the films Monument Men and The Woman in Gold. This really happened, and the Germans confiscated art from private families, from museums, from art dealers. And this is Joseph Goebbels, who was the Hitler's minister of propaganda. And he collected all of this art together, thousands of works of art. And about 600 pieces of art were put into a show entitled Degenerate Art, which opened in Munich. Here's the Führer came for the opening, and then traveled to a dozen or so other Austrian and German cities. And among the works of art in this show are works by Picasso, Chagall, many members of the Blue Rider group, including Klee. And at the end of this tour, over several years, the works of art were either sold or burned. And one of the works that was spared, that was bought actually eventually by the Museum of Modern Art, is this very classic work of art by Klee called The Twittering Machine. And it's now probably one of the most important works in the Museum of Modern Art in New York. So after the skin, the most frequent organ involvement in scleroderma is the GI tract. And we know that Klee had problems with his GI tract. When he was going to one of the sanatoriums to rest, he wrote, "The diet, I imagine, is going to do me some good. The difficulty is more one of the mechanism of swallowing." So he had dysphagia, and he vomited a lot, we know that. He also had problems with the lower GI tract. He wrote, "I have qualms about traveling. It is absolute hell for me if I have an episode of diarrhea in the car. It does not happen every day, but I have to anticipate that it might." This is now 1939. His disease is worse. So the GI tract can be involved anywhere from the lips to the anus. So the oral aperture is diminished. The patients may have dry mouth or Sicca syndrome. They have dysphagia because of dysmotility in the esophagus or actually anywhere throughout the GI tract. They can have lower esophageal sphincter dysfunction with reflux, gastric emptying problems, small intestinal bacterial overgrowth leading to diarrhea, and rectal incontinence. So GI tract is very frequently involved and sometimes can be a very severe manifestation of the disease. Now he's beginning to get lung involvement. And so this is a chest x-ray illustrating the interstitial changes. He wrote, "I inhale as deeply as possibly. My dyspnea depends on the trail, whether going up or going down. It also depends on the weather. Maybe there's a Raynaud's phenomenon here. And it also depends on how much food I have in my stomach." So reflux. Now Klee, until the very end, didn't lose his sense of humor. And when it came to his difficulties with breathing, this really affected one of his loves was hiking and walking up mountains in Switzerland and other places, Italy and other places. But towards the end, he wrote, "To the little incline up to his house, this is now my Matterhorn." So he was in probably functional class 4 at this time when it comes to his dyspnea. So one of the challenges for rheumatologists and pulmonologists is to sort out the many different causes of dyspnea in a scleroderma patient. And they're listed here: pulmonary fibrosis, pulmonary hypertension, heart disease, reflux. Sometimes the chest wall is so tight from the skin you get extrinsic compression, anemia, or conditions generally unrelated to the underlying disease, such as COPD. So it's a very challenging process. Now, I don't know if we have any medical students in the audience, but I know some of the older clinicians will know what Occam's razor is. So if you're a student and you haven't been asked what Occam's razor is, you better listen, because some attending is going to ask you on rounds, what is Occam's razor? So Occam was a Franciscan friar in the 13th and 14th century, and was a theologian and also a philosopher. And he is famous for this statement: pluralitas non est ponende sine necessitate. Plurality must not be posited without necessity. This is the law of parsimony. And when your attending asks you this, what he or she is trying to get you to do is to take all the information you have and put it into one unifying cause or diagnosis. And so we would like to try and do that for the patient with dyspnea. So when your attending asks you about Occam's razor, after you tell them in English, if not in Latin, what it is, you then ask your attending, well, what about Chatton's principle? Because they don't tell you about this. So this is the anti-razor. And the anti-razor is whenever some affirmative proposition is verified about things, if one thing does not suffice to verify a proposition, one must posit two. And if two do not suffice, three. And so on to infinity. And so many times when we're working up a patient for dyspnea, a scleroderma patient with dyspnea, one may not suffice, and then we have to think about two or three. Now there's a more modern version of the anti-razor, which is known as Hickham's dictum. This is John Hickam, who was the chairman of medicine at Indiana University. His father was a famous military figure. Hickam Field at Pearl Harbor is named for John Hickam's father. And Hickham's dictum says a patient can have as many diseases as he damn well pleases. So when it comes to dyspnea in the scleroderma patient, we have to think about all of these, either one or multiple ones. And so we often need the expertise of our pulmonologist, our cardiologist, our radiologist, our gastroenterologist to sort it out. And more often than not, it's not a single cause for their dyspnea. But nevertheless, this is a major problem for our scleroderma patients. And the importance of this is shown in this slide, also from Pittsburgh, where they looked at patients with scleroderma who had end-stage lung disease. And they went back and they looked to see what happened to their lung volumes, or in this case, their forced vital capacity. And you see most of the loss in forced vital capacity occurred in the first 4 or 5 years. So this tells us there may be a window of opportunity. It's very important to diagnose this early and to intervene if possible. And so we rely on pulmonary function tests, which I won't go into. We also rely on chest high-resolution computed tomography, HRCT. This is the imaging test of choice. I hardly ever do a chest x-ray unless somebody comes in with an acute process and I'm worried about pneumonia or pneumothorax or pulmonary embolism. The test of choice is a CT. You usually see, for rheumatology fellows and pulmonary fellows, an NSIP pattern. And we rarely biopsy our patients because we know their underlying disease is scleroderma. Unless you're worried about malignancy, we don't usually biopsy them, unlike the IPF patient who is being seen by the pulmonologist. People are working on quantitative CT scanning that may be more sensitive than just reading it by a radiologist or a pulmonologist. But the point is the extent of disease on CT scan predicts the disease course and predicts mortality. So a number of years ago, we did the scleroderma lung study, which was a multi-center trial. The results were published in the New England Journal of Medicine. And in this study, we showed that cyclophosphamide given as a daily oral treatment for 12 months improved the forced vital capacity in patients with scleroderma compared to those who received placebo. It also improved the skin. So it really was the first study of any drug in a randomized controlled trial to show an effect on the skin as well as the lung. The problem was that once the cyclophosphamide was stopped at 12 months, patients were followed for another 12 months. By month 24, they were back to where they started from, and no different than the placebo patients. So this led to SLS2, Scleroderma Lung Study 2, which was published last year. In this study, patients received mycophenolate for 2 years, and the control group got cyclophosphamide for 1 year, followed by placebo for 1 year. So they were followed for 24 months, and the primary endpoint was the change in forced vital capacity. And this is basically the primary endpoint. So in these patients, red is cyclophosphamide, blue is mycophenolate. Both groups showed a slight but statistically significant improvement in FVC. And there was no difference between the two drugs. So remember, cyclophosphamide for 1 year or mycophenolate for 2 years. Improvement in FVC and no difference between the two immunosuppressive regimens. And this is the skin score, modified Rodnan skin score. They both improved, lower is better. They both improved and no difference between the two. The real difference between these two treatment regimens was how well you could tolerate being on them. And that was strongly in favor of mycophenolate. So sort of the standard of care now is to use oral mycophenolate to treat scleroderma interstitial lung disease. Now we're now getting ready to do SLS3, in which all patients will get mycophenolate and half the patients will receive pirfenidone, the antifibrotic agent that's FDA approved for idiopathic pulmonary fibrosis. So in another 4 or 5 years, we'll know if adding an antifibrotic drug to an immunosuppressive drug is superior to immunosuppression alone. The other pulmonary manifestation of scleroderma that is important in terms of mortality is pulmonary arterial hypertension. Here, the rule is have a high index of suspicion, especially in patients with the limited form of the disease. And so your milder scleroderma patients in terms of skin, and especially in those who are anti-centromere antibody positive. And we use the echocardiogram as a screening test. It's not a great screening test, but the point I would make is you cannot diagnose pulmonary arterial hypertension without a right heart catheterization. So even if the echo is accurate in telling you what the estimated RVSP is, it doesn't tell you if that's pulmonary arterial hypertension or pulmonary venous hypertension because it doesn't give you the wedge pressure. So you need a right heart cath. I have a low threshold for ordering a right heart cath in my patients because the earlier you diagnose it, the more likely they are to respond. There used to be many people were therapeutic nihilists because when you diagnosed PAH, it was basically a death sentence. The 1 year survival was 10%. And now, since the introduction of first epoprostenol, Flolan, there are now at least a dozen, I think 14 drugs FDA approved for pulmonary arterial hypertension. And I won't go into this in any detail, but those 14 drugs basically target these 3 pathways. So we have endothelin receptor antagonists. There are 3 of those now that block endothelin. We have drugs like sildenafil, tadalafil, and now riociguat that augment the nitric oxide or the cyclic GMP pathway. And we have a variety of drugs that augment prostacyclin, and these drugs are either given orally, intravenously, or inhaled, or subcutaneously. So a lot of drugs now, very complex, and this really requires a dedicated pulmonary hypertension center to help manage. The role of the rheumatologist and the role of the internist is to make the diagnosis, and that involves PFTs, echocardiogram, and right heart cath. So back to our patients. Our patient, Klee, began to talk about pain in his hands, speculated that he had arthritis or maybe contractures because he went to much broader brush strokes than he did in those, compared to those very early works of art. This is one of his classic works of art, paintings done in the last year of his life, Captive. This is the Klee self-portrait, and these are the bars. He felt imprisoned, maybe because of his skin disease, but certainly also because he wasn't in Germany, he was in Switzerland. His art really wasn't accepted by the Swiss any more so than it was by the Germans. And he had applied for Swiss citizenship and it was denied. Again, mainly because of the political leanings in Switzerland, not so different than in Germany. And he was only granted Swiss citizenship posthumously, about 10 days after he died. He had skin disease. You can see between 38 and 40 some changes here. The skin looks tight. Skin over the nose is stretched tight. And he has what I think are either contractures or he's lost his distal fingers, although I can find no record of that in any of his diaries or letters. But clearly his fingers look abnormal in that regard. So in 1939, his wife wrote, "Doctors have finally given us a diagnosis, vasomotor neurosis." And if you go back to some of the older internal medicine textbooks from the 20s and 30s, scleroderma was actually listed under the category of vasomotor neuroses. So I believe that by 1939, they had diagnosed him with scleroderma. One of his last works of art, this is believed to be a self-portrait of Klee, lifeless, faceless, in a boat. And this is goes back to Greek mythology. This is Charon rowing the dead across the river Styx to the kingdom of Hades. So how was he treated? Well, we know he got theobromine, which would be a good diuretic, and digitalis. He got some heavy metals, liver extract, vitamin C, and massage. So nothing very specific. And this is really his last painting, Death and Fire, Tod und Feuer, white death mask, the German word for death, T-O-D. I think there's another T here, O, and this is a D. So he knew of his own imminent death. In 1940, he went to Locarno to enter a sanatorium. His wife came in May 18th. She wrote, his condition was fair at first, suddenly became very ill. He was fighting for his life, and he died on June 29th, 1940. And the cause of death on the death certificate was heart disease. So how would he be treated now? Well, these are the three facets of the disease: vascular, autoimmunity, and fibrosis. We have a lot of drugs directed towards the vascular aspects of the disease, ranging from calcium channel blockers, nitrates, ACE inhibitors, PDE5 inhibitors, endothelin receptor antagonists, prostanoids, and riosequat. Depending on what feature of the vascular disease you have, patients get one or more of these drugs. In terms of autoimmunity, it wasn't specific in terms of when to use these drugs, but we have methotrexate, cyclophosphamide, MMF. No talk on rheumatology is complete without mentioning vitamin R, rituximab, IVIG, and I'll come back to stem cell transplants in a moment. So he might have received one or more of these agents. The real next step forward in treating scleroderma will be the use or the development of antifibrotic agents. And Big Pharma is very interested in this, not because scleroderma is such a prevalent disease, but if you look at causes of death in the developed world, 45% of all deaths are due to fibrosis. fibrosis of the lung, heart, liver, kidney. So if you can find a drug that's antifibrotic for scleroderma, it's quite likely that it will have much greater implications for more prevalent diseases. So I'll just close because you'll hear soon about the Scott study. This paper has been accepted for the New England Journal of Medicine and will be published soon. This is the Scott study, which was stem cell therapy compared to cyclophosphamide. So these were scleroderma patients in the U.S. at about 12 different centers who had very severe scleroderma. They were randomly assigned to get monthly IV cyclophosphamide, that's the control group, or autologous hematopoietic stem cell transplantation with total body irradiation and anti-thymocyte globulin. And the Scott study showed, or will show, on your left, this is event-free survival. On your right, overall survival in the treated patients. And you can see for both of these endpoints, after 2 to 3 years, the two curves really separate in favor of stem cell transplantation. What's different, and this confirms some of the work done from Europe, what's different is the treatment-related mortality. In the European studies, the treatment-related mortality from the stem cell transplant itself was 9 or 10%, which in my mind was too high for most patients. But in the Scott study in the U.S., the treatment-related mortality is 3%. So this may be acceptable for some patients with the severe forms of scleroderma. So you have to stay tuned, but it will be coming out soon, and your patients may be asking you about it. So just to conclude, I've gone over the more recent classification criteria, which have greater sensitivity and specificity than the older criteria. I've tried to emphasize that scleroderma is a fibrosing, vascular, and autoimmune disease. The treatment has to be directed to each of these diseases. And as we begin to understand more about the molecular basis of fibrosis, this in turn should lead to more effective treatments for the fibrotic aspect of the disease. And I will end there, and I'm happy to answer any questions you may have. Thank you.
Thank you. That was fabulous. You certainly framed this disease differently than I'd ever thought about it before, and I love Paul Klee's work. I had no idea. And for the record, guys, I had no idea he was going to talk about an artist when I talked about
You set me up.
earlier. To start off, I do have one question. I was actually finishing up my internal medicine training when Captopril came out. And so I remember very vividly, suddenly people that had been dying of scleroderma renal crisis weren't dying anymore. Why is it that this drug works so well in the kidney but not in the lung?
Well, that is an interesting observation and a difficult question to answer. So the Captopril study story was fascinating. Dr. Leroy had come to Charleston from New York at Columbia, and there was a very famous hypertension specialist there named John Lara. And John was doing work with Squibb, the pharmaceutical company Squibb, on this new drug, which didn't even have a name. It had an SQ and a number after it. And they were developing it for systemic hypertension. And Carwile said, well, we should try this in scleroderma renal crisis, because nothing worked. When I was an intern in 1975, 76, I had a patient with scleroderma renal crisis, young woman, I'll never forget it. We had her on every drug we knew of to treat hypertension, and we couldn't control it, and she went on to renal failure. She was on, I'm dating myself, guanethidine, hydralazine, propranolol, Aldomet, and I think Lasix, and couldn't control it. So Captopril was a big step forward, and This happened right before I came to Charleston, but I did eventually meet the patient, 1980. Patient gets admitted to the Medical University Hospital with scleroderma renal crisis. He's in the ICU. Leroy calls up Lara, says, I got the patient. They somehow get IRB approval, which wasn't so difficult in those days. One of Lara's junior faculty flies from New York with the drug in his briefcase. I'm not making this up. Charleston was fogged in that night. The plane couldn't land. He landed in Savannah, took a taxi from Savannah to Charleston. They gave him captopril. Blood pressure came down, creatinine normalized, and he never required dialysis. But I'm dancing around your question because I don't have an answer except that vascular beds are different, and actually captopril, although it's a great drug for scleroderma renal crisis, there are some instances where it doesn't work, and we use other drugs as well. But captopril was used for pulmonary hypertension, but it's been superseded by all of these other drugs that seem to be more effective.
Any questions from the audience? Neil?
Right. Well, the stem cell transplant is still out there. You know, the real hurdle there now, once this gets published, maybe it won't be so difficult, but it's getting the insurance companies to cover it. You know, when you look at the two drugs that were approved for IPF, pirfenidone and nintedanib, none of them improved the forced vital capacity. What they did was they changed the slope, the rate of decline in FVC, and really didn't prolong survival. So they're not. But again, IPF is a different disease. It's usually UIP and not NSIP. And so what we saw with cyclophosphamide and mycophenolate in scleroderma lung disease is different than what has been seen in IPF. And so scleroderma patients seem to respond better, at least to immunosuppressive drugs. The question will be, will they respond also to adding an antifibrotic? I personally don't think these are great antifibrotic drugs. I think we'll find better ones. Ken and I were talking beforehand. So tocilizumab, which is FDA approved for rheumatoid arthritis and Still's disease, is now being looked at very carefully in scleroderma. We should know next year if the FDA is going to approve it. They already gave it fast track status. So the trial that's happening now will be the pivotal trial. And IL-6 clearly is involved in scleroderma. This goes back 30 years. It's been known that scleroderma fibroblasts make more IL-6, and if you add IL-6 to fibroblasts, they make more collagen. So blocking IL-6 may be an approach for the future. Tocilizumab may be the first biologic to be approved for scleroderma. We'll have to wait, but not too long.
Speakers, our town, we present you with a Louisville slugger. And thank you for delivering the Neudstadt lecture. This says Richard M. Silver, MD, Medicine Grand Rounds, University of Louisville, October 19th, 2017.
Thank you very much.
Thank you very much.
Thank you. This is beautiful. I won't take this to baseball camp in the spring, but I'll put it up on my wall and I'll treasure it. Thank you. Thank you. I had no idea you were going to set me up like that.
I'm just seeing on.
I thought maybe you would.
I did not know any of that about Paul Klee.
Yeah.
I know that's
fascinating. I've written two little papers. I'll send you PDF of when I wrote Fibrosis a number of years ago, and I've written one since. I'll send it to you since you like art.
You're one of my favorite teachers at USC.
Oh, GI. I didn't know you were a teacher.
Yeah.
I hope I didn't embarrass you as an USC faculty.
USC is a great place. Still bring the Hopkins.
Yeah. Yeah. I love to teach.
I know.
Yeah, I taught Brenda.
I know, you taught me too.
So you're a GI doctor. Good. How long have you been here?
I've actually been here since 2000. So I've been here.
Now I'm feeling all right.
No,
Isn't she?
well, thank you very much.
Thank you. Nice to see you.
So I'm Nelson Seabrook. I just wanted to introduce myself. I'm one of the chief residents this year, but I was at USC for medical schools.
Seabrook is across South Carolina, Maine. So you're a chief here?
Yes, sir.
Good. Good. So our guys are doing good?
They are. They're doing quite well.
Good. Always good to see you.
Thank you. I enjoyed your talk.
What are you doing next year?
I'm applying for gastroenterology fellowship.
They're really popular now.
Yeah,
It
yeah.
is interesting.
My brother's a GI doctor, so it's too much work. I see what he does. Actually, my brother says there's so many so little time.
Where is he?
He's in Knoxville, not too far. But listen, I went to baseball camp last year, and my coaches were saying, I'm not disappointed.
Yeah.
But so this is thank you.
We're gonna go just have it sit in the chairs, the seats, and do a couple of pictures
Oh, okay.
with the new
Shall I take
stats.
my bat?
Yes, please.
Okay.
Yeah. So.
Thank you. I'll see you later.
You're part of this now.